So hey guys, welcome back to Jabstudiesmetfun for Medicine Part 8. Before I start with today's topics, I would like to discuss about what this series is entirely all about once again. So guys, subjects like medicine and surgery, which I'll be covering in the upcoming months, these are going to be quite lengthy of subjects. And whatever I'm covering is not just PYTs, it's actually what I studied for my examination. I had given the June examination in which the passing rate was around 9.6% out of the total 25,000 students which we gave. The reason why I'm saying this is not because I'm boosting my rank or something, it's because using just these topics, I was able to get that rank. So our logic is simple in this, in all the 19 subjects is, whatever I have studied, I'm going to teach you guys that. Nothing less, nothing more than that. Okay. And speaking with respect to topics like medicine, it's going to be quite vast. So I'm going to try to cover a lot of things a bit fast. My speed also might be a bit fast, but I really expect your cooperation, because then only we'll be able to complete this. Because right now in my mind is I'm like trying to get medicine done as quick as I can so that I can focus on the other subjects as well. Okay. Doing these topics along with PYQs, 5 years FMG, 5 years NEET PG, 3 years INICET, again like every time as I say, is more than enough. Okay. So with that said, let's start with medicine part 8. We're going to start with congestive heart failure. Okay. So first of all, guys, what is congestive heart failure? Congestive heart failure, decode the word congestion. There is a lot of fluid around. So congestive heart failure basically means the heart is not able to pump enough blood to the body. Simple and easy as that. Okay. So the heart is not able to pump enough blood to the body. What are the markers which you're going to check? The marker which you're going to check in case of congestive heart failure, guys, is going to be BNP, where BNP stands for B-type natriuretic peptide. It stands for B-type natriuretic peptide. Now, what are the symptoms you see in congestive heart failure? Anything which is associated to the heart, you are going to see the patient is going to sweat a lot. The patient is going to have palpitations, difficulty of breathing. He was fine like this when sitting. All of a sudden, when he lied down, he had difficulty of breathing. That is known as orthopnea. He was completely fine throughout the day. And after that, what happened was that during night, all of a sudden, he had difficulty in breathing. That is known as paroxysmal nocturnal dyspnea. And classic thing which you will see over here is you will have pink frothy sputum. What is the criteria which is used in which you find the signs and symptoms of congestive heart failure? That is going to be the Fmge criteria. Okay, and the diagnosis is going to be congestive heart failure. Now, congestive heart failure, guys, can be a heart failure, can be a right-sided heart failure or the left-sided heart failure. So let's talk about the symptoms and signs. The first thing when you see on examination is the patient is going to have tachycardia. So before we start about the symptoms, let's see about the general anatomy in a quick way. The left side is basically from like what happens is from the pulmonary veins, oxygenated blood comes and it reaches to the left atrium. Correct? From the left atrium, it goes down to the left ventricle. From the left ventricle, it goes throughout the body. The right atrium receives blood from the superior vena cava, from the inferior vena cava, and from the heart itself for the coronary sinus. Correct? So from here, what? These are all the deoxygenated blood. From the right atrium via the valve, which is known as the tricuspid valve, it goes to the right ventricle. From the right ventricle, it goes to the pulmonary trunk and goes back to the lungs so that it can get oxygenated. From there, it comes back to the left atrium. That much we all know. So talking about this, let's talk about the symptoms. Now you will be able to understand a bit. Let's start with your left side. So as I said you, the left-sided part of the heart is responsible to pump out blood to throughout the body. So if you're having failure of the left side, if you're having the failure toward the left side, then you will not be able to pump the blood. That is why the blood pressure is going to be less. Okay. So you know that after the blood is going to be pumped, it's going to be various parts of the body. What is urination? Urination is just basically filtration of the impurities from the blood. So if there is less blood, there will be less filtration. That is why your patient is going to have oligouria. When you use the bell of the stethoscope, you find a unique thing which is the S3 sound, which is basically a ventricular gallops rhythm, okay, which is specific for left ventricle failure. Now, because guys, there is too much congestion over here, there is too much blood over here, and it's not be able to pump out to the body, this congestion goes upwards from the pulmonary veins to the lungs, thereby causing a condition which is pulmonary edema. And how do you figure out it is pulmonary edema? When you use the stethoscope, you will have crackles or crepitations. So these are some of the signs of left ventricle failure. So the blood pressure is going to go low, no urine or very less urine. Patient is going to have a classic sound that is going to be a ventricular gallop sound, which is a low pitch sound heard by the bell of the stethoscope. you will have pulmonary edema, which will be heard as like bilateral crackles or crepitations. Let's go on with the right side of the heart. I told you the right side of the heart, it carries blood from the right ventricle. Right ventricle, you'll go from the like to the pulmonary trunk and to the lungs, correct? So basically guys, as I said you that there is going to be the superior vena cava, inferior vena cava and coronary sinus. You know that basically how do you assess the functionality of the right side of the heart? That is with the help of the JVP, that is the jugular venous pressure. It helps us to figure out what is the functionality of the right side of the heart. Now why do you think that there is going to be JVP raised? Because you see the JVP is usually checked by the jugular veins. The jugular, if there is again congestion over here, the jugular vein pressure also is going to rise. That is why you're going to have raise in JVP in the right side, right ventricle failure. JVP is a marker for checking the functionality of the right ventricle. What is Kussmaul sign? There is two things guys. One is going to be Kussmaul breathing and another one is going to be Kussmaul sign. Kussmaul breathing, which is seen usually in diabetic ketoacidosis, is actually deep, fast, rapid breathing. It is not as same as Kussmaul sign. What is Kussmaul sign guys is, usually whenever you are inspired, because of inspiration there, air will cause a positive pressure due to which you will have a decrease in JVP. Usually the JVP is going to fall at the time of inspiration. But when JVP does not fall at the time of inspiration, that is known as Kussmaul sign. And just now we read that in right ventricular failure there will be JVP raised. So right ventricular failure, even at the time of inspiration when the JVP is raised, that's why this is known as Kussmaul sign. Now, because as we told you about the pathway, right? So the superior vena cava from upper part of the body, inferior vena cava from the lower part of the body collects the blood and goes to the right atrium. So you also know that there is going to be like inferior vena cava over here, collecting it from here and going to the right atrium of the heart. So that is why, because if there is in the right side of the heart, just imagine if this is the right side, congestion is going to be there. The congestion is going to go up and go and involve as well as in the liver. Thereby you will have hepatomegaly, and that is also going to be painful. So you're going to have hepatomegaly, which is going to be painful. You're going to have raised JVP, and if this condition is led by chronically, because further congestion will be there, you will have pedal edema and sacral edema as well. But this is seen only in the chronic condition. So these are nothing but a comparison of what are the symptoms between left ventricular failure and right ventricular failure. So let's talk what is the workup. As I already told you, whenever you have congestive heart failure, the test which is going to be B-type natriuretic peptide. So the blood test which you are going to do is going to be B-type natriuretic peptide. Investigation of choice. You want to see the heart 3D in a 3D way. So that is why you're going to do a cardiac MRI. If you don't have the choice of cardiac MRI, the next best thing is going to be a transthoracic echo. As I said you, the marker of congestive heart failure is going to be BNP. Similarly guys, we'll now compare and we'll integrate and study. The marker for MI is going to be drop I. It's going to be elevated, correct? So now guys, if you do an X-ray of the congestive heart failure, what are going to be the signs? So these are the basically the features over here. Let's remember it with the easy alphabetic order of A to E. A stands for alveolar edema. Because of alveolar edema, you'll have the classic thing which is known as bat wing appearance. Because of the alveolar, now why there is alveolar edema? Again, because of the congestion and going up, right? So then you will have a bat wing appearance over here. B stands for curly B lines. B stands for curly B lines. What is curly B lines? It is nothing but lines which are seen perpendicular to the pleural surface. Perpendicular to the pleural surface. C is cardiomegaly. And what is cardiomegaly guys? When the cardiac thoracic ratio is more than 0.5 or more than 50%. That is cardiomegaly. D stands for dilated upper pulmonary veins. Because of dilated upper pulmonary vein guys, you will have the moustache sign or you will have the antral sign. You will have the reverse moustache sign or the antral sign. You can see like this. It's like an antral of the deer or a moustache, right? And E over here is pulmonary effusion. Oh sorry, pleural effusion will be there. So basically, how do you see pleural effusion guys? You will see the blunting of the costophrenic diaphragm. So if you see over here, what was there? Starting with A, that is going to be alveolar edema, which will give you a bat wing appearance. B will be curly B lines. C is going to be cardiomegaly. D is dilated upper pulmonary veins, due to which you will have reverse moustache sign or you will have the antral sign. And E, which is going to be pleural effusion. Okay, talking about the actual sign over here, these are the ones which are perpendicular to the pleural surface. These are your curly B lines. Okay, over here you can see classic thing, which is your bat wing appearance. These are your bat wing appearance. Okay. Over here you can see the like cardiomegaly over here, and remember there is no tracheal deviation. Now earlier in our medicine and as well as radiology we talked about deviations, right? Remember, ipsilateral deviation is going to be seen in collapse or atelectasis. Contralateral deviation is going to be seen in pneumothorax or pleural effusion because of mass effect, correct? So then these is the basic mnemonic, as I said you, A, B, C, D, E. So like this, you can remember the findings of congestive heart failure. Next guys, further, there are many types of cases. You will see there are multiple types. One is going to be acute congestive heart failure. Other is going to be chronic congestive heart failure. There are other two types in which the heart failure with preserved ejection fraction or with reduced ejection fraction. What is ejection fraction, guys? Ejection fraction is nothing but a ratio which is between the stroke volume and the end diastolic volume. What is the stroke volume? The volume of blood which is pushed out of the blood of the heart, that is going to be around 80. And diastolic volume is after the push, how much amount of blood is remaining in the heart, that is going to be your end diastolic volume, and the ratio is almost going to equal to 65%. It's going to be almost around 65%. So now what is something which is known as heart failure HREF, where R over here stands for reduced ejection fraction, and this condition can give you a severe condition of acute pulmonary edema, a sudden onset, and this is an emergency condition. Remember, what is the definition of heart failure with reduced ejection fraction is whenever the value is less than 40. So what is the management? Remember guys, for three conditions, one is going to be acute congestive heart failure with reduced ejection fraction, and for acute pulmonary edema, the management for these three conditions is same, that is going to be LMNOP. Again, same order, LMNOP, where L stands for Lasix, which is nothing but a furosemide. M is morphine. The role of morphine is to reduce the oxygen consumption and to reduce that acute condition which is pulmonary edema. Third is going to be nitrates. What nitrates is going to do is it's going to cause vasodilation, thereby decrease the blood pressure and it reduces the stress on the heart. Oxygen will be there using a non-invasive ventilation and positioning. Now why positioning over here, a semi-supine positioning is preferred over here, so that it helps us to decrease the venous return, again to put less load on the heart. So this is the management LMNOP for what guys? Acute congestive heart failure, acute pulmonary edema, and heart failure with reduced ejection fraction. What about for conditions like chronic heart failure? In case of chronic heart failure guys, a combination of ACE inhibitors and beta blockers are used. Why ACE and beta blockers guys? Because they are mortality reducing drugs. They are mortality reducing drugs, and it basically helps us to prevent the causes of death in a much more significant way. Another one in the options will be nitrates and calcium channel blockers. Guys, these are not used and not preferred for chronic heart failure. Why? Because they are not reducing the mortality rate. Okay. Along with that, you will be using spironolactone. Now, why spironolactone in this condition is because guys, in acute condition, there was no pedal or sacral edema. To reduce this edema, we are going to use an aldosterone receptor blocker, that is going to be spironolactone. Okay. What is a side effect of spironolactone? Commented right now. We'll talk about it later on. Okay. So along with this, you will have a salt restricted diet as well. In some people might ask, why don't we use thiazides? Why are we using only loop diuretics? Because thiazides have a side effect, which is hypokalemia. Hence, we don't give it. Okay. Next condition, guys, we're going to talk about heart failure with preserved ejection fraction. Preserved ejection fraction means that the heart, the value is not less than 40, which we talked about in reduce. It is more than 50. So what are the management? The management is again going to be drugs, and these drugs are going to be ARNI. ARNI are nothing but androstenedione receptor blockers along with naltrexone inhibitors. So if you ask what are the name of the drugs, it is a combination of valsartan and sacubitril. Now let's integrate pharmacology in this, because many questions have been asked in the mode of action. Now ARB receptors, okay, except specifically valsartan is also used in hypertension as well. But if you talk about sacubitril guys, what sacubitril does is it is going to be inhibiting the BNP degradation, thereby causing you natriuresis. What is natriuresis? Is flow of salt. Because NaCl is also getting flowed out, water is also going to get flowed out, thereby our stress on the heart is going to reduce. Okay, and I got along with that, heart failure with preserved ejection fraction has a risk of edema. That's why again you're going to use spironolactone. And as we were discussing, a side effect of spironolactone is going to be gynecomastia, because it goes and stimulates the E2 receptor. Another modified drug furthermore than spironolactone is epirilinone, and this drug does not have the side effect of gynecomastia. Now for those who are done with pharmacology, gynecomastia is caused by certain drugs, and these drugs are remembered by disco K drugs. Okay, if you remember these drugs, very good, but if you don't, make sure you comment below. And even though I don't know you're watching this video right now and as soon as posted, maybe 1 year, 2 years, 3 years, but you have to comment irrespective of you've seen maybe there are 100,000 comments already, because you are going to give the exam yourself, and whenever you're going to type it out, even you know the answers are there, but you're going to type it because these are your efforts, and later you will be proud that yeah, you were able to write it. And whenever you give a significant effort to your work, that memory will be retained for longer time. Okay, next let's talk about what are the causes. Now the cause, guys, of a congestive heart failure, specifically with heart failure reduced ejection fraction, is going to be ischemic cardiomyopathy. What is the management? Same, congestive heart failure, acute one, heart failure with reduced ejection fraction, or pulmonary acute pulmonary edema. The management is going to be LMNOP. Okay, chronic one we just now talked about. You're going to use an ACE inhibitor and beta blocker, and to reduce the edema, we're going to give an like aldosterone like a receptor blocker, that is spironolactone. Usually what they say is heart failure with preserved ejection fraction is caused by hypertension. That is why we are going to give an AR2 blocker, and along with that you're going to give an early pressin inhibitor, that is going to be sacubitril. Aldosterone is given over here as well to reduce the edema. In case of congestive heart failure, we also use one drug that is known as digoxin, a very important pharma topic, but let's discuss it quickly right here right now. The mode of action of digoxin, guys, is a sodium potassium pump inhibitor. Now because it inhibits sodium potassium pump, what happens is the intracellular calcium is going to increase. Since calcium is increasing more inside, and you know calcium is responsible for contraction, and this contraction thereby increases the force of contraction of the heart, thereby helping the heart to pump out more, so the blood can pump out more. The main problem was congestive heart failure was not able to pump enough blood, so this role helps to pump the blood more. And whenever you have any drug which is causing increase in force of contraction, that is considered as positive inotropic drug. Okay, positive inotropic action. But this had a side effect. Because of increased force of contraction, obviously you need more oxygen, so thereby the oxygen demand was increasing. Thereby it was basically causing hampering also at one time. So what our body mechanism does is the vagus nerve. Vagus nerve helps to decrease the heart rate. Any condition which causes decrease in heart rate, that is going to be a negative chronotropic effect. Thereby this was useful so that it reduced the O2 consumption. Okay, let's talk about these side effects. There are two types of side effects with respect to digoxin. One is going to be your extracardiac and the cardiac side effects. Extracardiac side effects are more common, and the most common type is going to be your nausea and vomiting. The more common type was nausea and vomiting. If they'll ask you what is the specific extracardiac side effect of digoxin, that is going to be xanthopsia, which is nothing but yellow vision. It is nothing but yellow vision. If they ask you specifically what are the cardiac effect of digoxin, the most common type is going to be ventricular bigeminy, and the drug of choice for ventricular bigeminy is going to be lignocaine. The drug of choice for ventricular bigeminy is going to be lignocaine. But if they ask you what is the specific cardiac effect of digoxin, that is going to be non-paroxysmal atrial tachycardia associated with AV block. It's a long name, so make sure you try to remember it. How can you remember it? Write it in front of a sticky note that digoxin ka specific factor was non-paroxysmal atrial tachycardia with AV block. Or maybe you start discussing, all of a sudden you ask your friend randomly, "Bata iska specific side effect of digoxin in the cardiac region kya hai?" Okay? So like that you have to remember these things, because these can be asked. Okay, it's kind of difficult to remember, so these most probably can be asked as one-liners. Okay, so these are the side effects, the most common types with respect to digoxin. Next, guys, another important topic with related to forensic medicine, but some kind of medicine also comes into it, so let's talk about it. They will ask you guys, in a one brain dead donor, how many lives can that patient save? One brain dead donor, how many lives can he save? He can save, at least he or she can save 8 lives. And how can he save 8 lives? Because you can donate and you can use 2 of the lungs. Okay, you can use both of the kidneys, you can use 1 liver, pancreas and intestine. Counting all of them, it's totally 8 lives can be saved by one brain dead patient. What are the most common cause of transplants? Let's talk about that as well. The most common cause of heart transplant is going to be cardiomyopathy. In cardiomyopathy, dilated cardiomyopathy is more common cause than ischemic cardiomyopathy. Okay. In lungs, the most common cause of transplantation is fibrosis. Okay, interstitial lung fibrosis. In kidney, a very important type is obviously nephropathy, but remember, diabetic nephropathy is much more common cause of kidney transplant than hypertensive nephropathy. Okay, in liver, it is going to be the cancer, which is hepatitis C cirrhosis, thereby causing cancer. Pancreas, for type 1 diabetes mellitus, is a common cause of transplant of the pancreas. And in case of intestine, short bowel syndrome, anything less than 200 centimeter, we'll talk that much in surgery. But these are the common types of cause, which are the most common cause of the transplant or the specific disease. Again, guys, remember, one brain dead patient can give up to 8 lives, can save up to 8 lives. Okay, talking about now brain dead, let's define what is brain dead, right? So whenever you talk about brain dead, guys, basically nothing, it means brain stem death. What is included in the brain stem, guys? It is going to be your midbrain, pons, and medulla. 3 of these together combined, and these are known as the brainstem. And now, how can you, obviously you can't go check inside what is there, but you can based on the cranial reflexes, you can find out whether this is functional or not. Okay, first of all, you need to know any glossoma scale value less than 8 is considered as coma. Okay, how do you see the functionality of the midbrain? Again, this is the order only: midbrain, pons, medulla. So midbrain, remember this order also. Okay, so midbrain is checked by the light reflex. When you put the light and you see there is the pupils are fixed and they are not reacting to light. Okay, remember what cranial nerves are involved: 2 and 3. Next, to check the pons, you will have the corneal reflex. In the corneal reflex, you have the trigeminal nerve, and then you have the facial nerve for the response. If you have and you use a cotton like a stick, like the the ear, the one which you clean your ear with, and if there is no blink, then that is going to be considered absent. The medulla is checked with the help of the glossopharyngeal nerve and the vagus nerve, with the help of eliciting the gag reflex and the cuff reflex. If you are not able to elicit it, it is absent. Calorie stimulation test with respect to water, hot and cold, if that is also absent. Oculocephalic reflex, also known as the Dolly's eye reflex. Basically what it means is, if right now I'm going to rotate my head like this, you can see that my head and my eye are independently moving, because see, my eye is pointing here but still I'm moving my head like this. In case of a coma patient, there won't be this independent eye movement, and if you do like this, the patient will not have any independent eye movement. Okay, so that is also going to be negative. Once all of these tests are negative, after that, what you're going to do is you're going to do the apnea test. Basically what it means is that patient who is in ventilator, you're going to remove the ventilation and you will try to find if there is spontaneous breathing or not. If there is no spontaneous breathing, again the test is going to be negative. For confirmation of a brain dead patient, you need 2 doctors are required to confirm your diagnosis, and these 2 doctors they have to be PG doctors. Okay, they have to be PG doctors. Alright. Sometime, guys, when a patient is brain dead, you might be seeing that there might be some twitching of the hand, there will be some movement, something like this. This is not considered as brainstem involvement. As we talked about the brainstem involvement, these are the following things which you need to elicit to say that the patient is not brain dead. And then these can be, because remember the deep tender reflex can be elicited in these conditions because the spinal cord is still intact. Okay, so talking about brain dead conditions, and now let's talk about something with respect to trauma. Okay, you have a car crash patient who had a seat belt on. A very important PYQ: car crash patient with seat belt on. When you see that there was car crash, the paramedics came, they checked the vitals, heart rate was tachycardic and there was hypotension. What is this condition? Obviously there is bleeding. Further after, again when you check the vitals, you saw that the BP was unrecordable. Basically means there is internal bleeding. And this, whenever you have a seat belt on, whenever there is a question involved with seat belt on in trauma patient, this is nothing but a mesenteric tear. And guys, in mesenteric tear, the arteries which are involved are the superior mesenteric artery and the inferior mesenteric artery. A very important PYQ with respect to medicine as well as surgery. This is what type of shock? It is going to be hypovolemic shock. As I told you, it is because of a trauma and there is hypovolemic shock. Management is going to be quickly, you have to do exploratory laparotomy. Okay. Next, guys, with respect to car crash, you can have 2 types of traumas. One is, which we just now discussed, you'll have tachycardia, BP falling, and then later you see signs like bruising in the anterior abdominal wall, which gives you an indication that yes, there is internal bleeding over there. Management is going to be exploratory laparotomy, that is seatbelt syndrome. The shock which is seen over here is, which we already discussed, is hypovolemic shock. Hypovolemic shock. Another condition, guys, is when you see you'll have muffled heart sound, S1 and S2. The BP is going to be hypotensive and raised JVP. Okay, muffled heart sound, BP low and JVP. What is this triad, guys? This is your Beck's triad. And Beck's triad is seen in which condition, guys? It is seen in cardiac tamponade. It is seen in cardiac tamponade. The management in this condition is going to be an emergency pericardiocentesis, and the shock which is seen over here is going to be obstructive shock. So you get to know what are the differences. In case of a mesenteric tear, the shock is going to be a hypovolemic shock, while in cardiac tamponade, the shock is going to be an obstructive shock. The shock which is seen in post-MI is going to be a cardiogenic shock. Excuse me. And the cardiogenic shock, the management is going to be dobutamine and norepinephrine. Okay, dobutamine and norepinephrine. Next guys, what are the management in case of trauma, in case of shock and all? Obviously, first thing is you have to secure an IV line, and that is going to be circulatory management with the help of wide bore cannula. Whenever you talk about emergency like fluid resuscitation, the first two cannulas which are be there, okay, that this is going to be large bore cannulas. The larger the bore the cannula, more will be the flow rate. Simple and easy. We'll talk more about this in anesthesia, but for now let's know the basic things which you so you can integrate it and later on remember over there as well. Remember the order, it always starts with 14, okay, and add 2 to 14, 16, 18, 20, 22, 24, okay. The first number which you have to remember which has maximum fluid resuscitation is going to be orange, gray, green. You'll have the pink, which will be there. I'll tell you the mnemonic later on. Blue, yellow, violet. In which you have to remember the orange and the gray one are for fluid resuscitation. Green is going to be in case of males, in case of maintenance, for IVs, like for ceftriaxone, antibiotics. Pink is going to be for females, ceftriaxone, okay. Whereas if you see the 21, which is going to be a blue one, the blue one is usually seen in case of fragile patients like elderly or case of child. Yellow and violet, which will be there, 24 and 26 are basically for in case of neonatal ICU, in which 24 is going to be for a term child, while if you will see 26 is going to be for a preterm. Now how do you remember this? You can remember this with the mnemonic of "Oh great God, please bless your people." O, orange, gray, green, pink, blue, yellow, purple or violet, you know that. Okay, so you do like this, you have to remember this. These questions come, and make sure you don't make a fumbling mistake. Okay. Next guys, the topic which I'll be discussing in this, the last topic I'll be discussing in this video is JVP, a very important topic. That's why we started with congestive heart failure. Let's talk about a detailed explanation in jugular venous pressure. So how do you check the JVP? What does JVP check? JVP basically checks the functionality of the right side of the heart, that is measures the central venous pressure or the right atrial pressure. It is a biphasic pulse which is seen along the sternocleidomastoid. Each with one carotid pulse is equal to 2 JVP pulse. Okay, how are you able to find the pulse? Usually all veins have a valve, but the jugular veins, specifically the internal jugular vein, does not have any valve, due to which the column of blood basically tracks up, and then you will be able to find the pulsation. How do you check? You'll ask the patient to be in a semi-supine position with an angle of 30 degrees, and you see you'll apply a torch over here. Okay, let's talk about more detail in JVP. The normal pressure, guys. Remember, whenever you're talking about the normal pressure in water is going to be 5 to 8 centimeter of water. Okay, and in which vein is it checked, guys? It is checked in the right, more commonly than left, internal jugular vein. Okay, normally the JVP, because of the pressure difference, falls down on inspiration, but if it does not fall on inspiration, that condition is going to be Kussmaul sign. Okay, Kussmaul sign. In which other conditions do you see Kussmaul sign? Okay, the first condition is going to be constructive pericarditis. You will have conditions like restrictive cardiomyopathy, and the other condition is going to be, which we already discussed, that is going to be your right-sided heart failure. So CRR. Okay, where do you see Kussmaul sign? You're going to see it in CRR, constructive pericarditis, restrictive cardiomyopathy, and CRR. Okay, so so which are this? So where do you see Kussmaul sign, guys? You're going to see it in CRR, that is going to be constructive pericarditis, restrictive cardiomyopathy, and right-sided heart failure. Let's talk about now the JVP waveform. Talking about the JVP waveform, you need to know there are 3 peaks. One is going to be A, C, and V. There are going to be main 2 descents, which will be, that is going to be X and Y, and X prime will be a little more detail about it. Okay, so what you have to remember, as I told you guys, JVP is the measure of right side of the heart. So whatever is any pressure related to the right side of the heart, that is going to be called by the JVP. Okay, so how do you remember this is, as you know, the internal jugular vein is going to go and later open up to the right atrium. So guys, first thing what happens is the blood is received to the right atrium with the help of superior vena cava, inferior vena cava and coronary sinus. So once the blood begins to fill, there will be a time when the atria is going to contract. So over here, A stands for atrial contraction. Once the contraction is done, the blood flows from the atrium to the ventricle. That part is denoted by the X descent. Okay, so once the blood reaches to the ventricle, from the ventricle over there, you guys know that the tricuspid valve is also going to get closed and the pulmonic valves are also going to get closed, and then there will be contraction. When there is isovolumetric contraction over here, this tricuspid valve begins to bulge, and this bulge will be read in the JVP, and this bulge is over here C, where C over here stands for tricuspid bulge. Tricuspid bulge. Okay, so after the isovolumetric contraction, the pulmonic valve opens and the blood flows down. So that is why pressure is reduced. The pressure from the tricuspid valve goes down. That is why you're going to have this X descent over here. Once this is descent, so then over here you can see this is ventricular systole. Okay, so after this what happens is, once the full cycle is over, again the blood starts pooling in the atria. So that pooling of blood, this is venous filling. This is venous filling. So this venous filling over here is demarcated by this peak, that is going to be V. After V, then again the same cycle is going to open. There will be opening of the tricuspid valve, which is going to be now denoted by the Y descent. Okay, so to summarize, what happened over here is A stands for atrial contraction, A dash stands for atrial relaxation, C is for tricuspid bulge, and X is going to be for ventricular systole, V is going to be for the venous filling in the right atrium, and Y is equal to ventricular diastole. Okay, with respect to two markers over here, you need to know the C is equal to isovolumetric contraction. Makes sense, right? When there was an isovolumetric contraction, that is why there was a bulge to the tricuspid wall. Venous filling is there at the time of isovolumetric relaxation. That time only the blood is beginning to fill in the atrium. So this is your JVP waveform. Based on the abnormalities over here, we can find out the diagnosis. Okay, so just in a quick detail again what I spoke right now. A was your right atrial contraction. So this was the first pulse which we felt. After the contraction, there was relaxation. That was defined by X prime. Okay, then once the blood went from the right atrium to the right ventricle, there was isovolumetric contraction, due to which there is a bulge in the tricuspid valve, which was given as a sinus C. After the isovolumetric contraction, the blood flowed down, because of which the pressure from the tricuspid area went down, and then you had X descent. This X descent is nothing but your ventricular systole contraction, right? After this whole thing, you will have isovolumetric relaxation, in which the atria begins to pool in blood, that is given by the sign of V. Obviously, blood is getting pooled near the atria, so that's why near the atria the JVP is there, that is why the JVP is rising that time. And after that, there will be opening of the tricuspid valve, which will be nothing but your ventricular diastole, because that is now blood getting collected in the ventricle. This is all what you need to know about JVPs. Okay, let's talk about the basic pathogenesis furthermore. As I told you over here, A is atrial systole, C is isovolumetric contraction, V is isovolumetric relaxation, X is nothing but ventricular systole, and Y is nothing but filling, which is ventricular diastole. How do you check? You're going to pick in the semi-supine position, 30-degree angle using a light. Remember guys, how are you going to check the venous pulsation is by obliterating it by placing a finger near the clavicle. Check the markers guys. JVP is a marker for right-sided congestive heart failure. For left-sided congestive heart failure, another PYQ is you want to check the pulmonary capillary wedge pressure. Remember guys, the normal pulmonary capillary wedge pressure is going to be 8 to 12 mm of Hg. That 5 to 8 was in centimeter of water. Be careful in that. Okay, let's talk about some of the pathogenesis which you need to know. First thing is, where do you see a large A wave? Now, what do you mean by A wave versus atrial contraction? Now, if there is any condition which is opposing this contraction, which means if maybe the hole in which the blood is going, if it is too narrow, or if there is any obstruction, there is going to be increase in pressure in the atrium. So conditions like tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, which is inhibiting the flow of blood, these are all going to cause large A wave. Now, if you see why long-standing mitral stenosis is nothing but over here, right? So a long-standing mitral stenosis, which will be here, it causes the pressure to exert from here. It goes to the lungs. From here, it goes to the pulmonary artery. From here it goes to pulmonic valve, and over here it goes to the tricuspid valve. Thereby, this also can cause an increase of pressure in case causing a large A wave, right? Causing a large A wave. Okay, so these are the causes of large A waves. What about absent A waves? What it means? What is the meaning of absent A wave? Basically means there is no contraction. Conditions such as atrial fibrillation, when there is so much of the heart is trying to beat, but this is not proper contraction. It's not. It's something like twitching. Correct. What is the meaning of Canon A wave? It is a multi-large, like extra large A wave. When do you see these conditions? It is seen in AV dissociation. AV dissociation, which is atrioventricular dissociation, which means is the atria and the ventricle are contracting independently. Usually what happens is first the atria should contract, then the ventricle should contract. Conditions like complete heart block or conditions like ventricular tachycardia, where sometimes the atria and ventricle will contract together. Because of this contraction together, the pressure in the JVP is going to be much high. That is why you're going to have a condition like Canon A wave. Okay, where do you see absent X descent? What is the meaning of X over here? Remember I told you the meaning of X over here is ventricular systole. So basically blood pumping out, the blood which is going to be pumping out. Conditions like tricuspid regurgitation, in which the blood is not getting pumped out but it comes up, because of which you will have a large A wave but an absent X wave. That is your basically seen in tricuspid regurgitation. Due to which at the time of your ventricular at the time of V, which is venous filling of the right atrium, instead of the blood which was going out, it gets on collecting in the right atrium. That is why you will have a giant V wave which is known as a CV wave. You will have a giant V wave which is known as a CV wave, which is seen in severe tricuspid regurgitation. Okay, and also along with this you will have a steep Y descent. Okay. Along with this, which is another condition in which you will have absent Y descent. What was Y descent is that basically the blood is going to be pulled out, right? So ventricular diastole. Ventricular diastole. When do you see there will be a condition in which you are not being able to put the blood into the heart? That is your cardiac tamponade, which we just discussed. So you can see over here that there is so much fluid over here that you can't even fill the blood during the relaxation phase, because Y phase was nothing but ventricular diastole. What are the normal values you need to know? In case of the normal pericardial fluid, it is going to be 20 to 50 ml. Okay, what are the history you will have? You might have a car like a crash patient, directly a blunt trauma to the upper part of the chest. You might have an oat cell cancer, because oat cell cancer can go and migrate and cause malignant pericardial effusion. Triad, which we just not talked about, Beck's triad, which is nothing but muffled S1 and S2. You will have hypotension and raised JVP. The important PYQ over here is the JVP which you have raised over here is going to be non-pulsatile JVP. A very important thing is it's going to be a non-pulsatile JVP. Along with this, you will have absent Y descent. Why absent Y descent? Because there is no blood which is getting filled by. Okay, these are the pathologies, the pathophysiologies I am explaining. If you are not able to remember it, it's completely okay. Just try to mug it up. Make a paper like a sticky note and try to revise it every time. You'll be able to remember it. Come on guys, you're able to remember IPCs, so this is very easy in that way. But if you're able to remember it in a logical way, it is much more useful, because it will help you to retain it for a longer time. Other features which you find in case of cardiac tamponade is you'll have, again, which we already discussed, the management is going to be pericardiocentesis. You'll have something which is known as pulsus paradoxus. What is pulsus paradoxus, guys? Nothing. It is something like whenever you inspire, the BP or the pulse becomes low. That is known as pulsus paradoxus, which is seen in conditions like cardiac tamponade. You'll have an obstructive shock, which we already discussed. Where do you see an hypovolemic shock in case of trauma? That was mesenteric tear. Now another feature with respect to the JVP is when you have a condition like steep X wave and you'll have steep Y wave, steep Y, that is going to be considered as constructive pericarditis. Okay, so we have talked about all the conditions: large A wave, absent A wave, Canon A wave, where you have absent Y descent, in conditions which you have steep X as steep Y descent, that is constructive pericarditis. This lecture was a combination of both theoretical things with some explanation and few of the mugging up things. But I hope you were able to understand the JVP. Again, if you read these, what I have told with respect to JVP, with respect to congestive heart failure, with respect to trauma, whatever we talked, it is more than enough. You don't need to dig deep into these topics, and it is good enough for your examination. Last, let me know that if you know this, make sure that you comment over here. What is the answer of this triad? Make sure you read this every time before you start studying. Take care. See you guys in the next video. Bye-bye.